much for coming to this lunchtime session. Obviously, I think you know the previous session overran a bit, but I think we do need to get started. I think this is a very interesting session that's been put together and really looks at the past, present and future of heart valve therapies. And I think there's an awful lot going on in this space. I think you're aware that Edwards in the past and currently have been very involved and innovative in this field. So I'm Neil Moat. I know many of you. I'm co-chairing this with Inda Birdie, who I'll introduce. Inda has established an excellent minimally invasive surgical program at Basildon, and he's going to go through the Metronome of heart valve therapies. Thank you, Inda.
Thank you, Neil. Thank you, everybody, for attending. Actually, I'm not really going to talk to you too much about the work that I've been doing. I feel really privileged to be part of this faculty, and there's some real innovators in this room. And I don't just mean Edwards and all that they've done for the specialty over the last 30 or 40 years. I don't just mean the faculty themselves, but I also mean everyone in the room, because at the end of the day, what we're going to talk about today really depends upon how many of you decide to exploit these strategies to improve the care of your patients. So the line of my talk is really going to be the word innovation. Edwards gave me this slide to present. I felt an obligation to present it as it's their lunchtime session. But to be honest with you, many of these technologies we should be very impressed with. If we think about the evolution of Edwards, Lowell Edwards, at the age of 60, a retired gentleman, wanted to develop a mechanical heart valve. In actual fact, 2 years later, he developed the first, one of the best-known mechanical heart valves. And if you read the newspapers when the first of these were inserted in a human being, it was a revolution. It was a miracle. How could this beat immediately? How did they restart the heart? And you really thought, with this innovation, there really could be nothing else. Now, of course, with this came problems: anticoagulation, bleeding and thrombosis. And there came tissue valves made out of pigs and cows. And of course, if you read the newspapers at the time, you'll say, how can you possibly make a valve out of a pig or a cow? And I suggest that all of us go into work every week and insert a porcine valve or a bovine valve at some point in that week and think nothing of it. I think we've come to understand that tissue valves have a durability far better than we may have imagined, and that's changed the clinical spectrum. I'll just elucidate that briefly because we are short of time, and my colleagues are going to really delve into the depths of all of this going forward. I do remember as a registrar, transcatheter valves, I remember the problem with thrombosis, with annular rupture, with durability, paravalvular leak. I think all the surgeons in this room at one point felt that transcatheter valves really had no future whatsoever. I think every single person in this room now realizes that innovation is a real innovation and it's here to stay. Some people believe it's a complete game changer. I'm not sure that's strictly true, because I think that cardiac surgery still has an awful lot to do in terms of developing the landscape for patients. And of course, as we've understood tissue valves, we understand that if we can find a way to manufacture them better, and we might be able to make them even more durable than the ones that we use today. This is a graph, a busy graph. I just put it up to demonstrate the volume of data that we know about the perimount tissue valve, and also other valves that we know on the marketplace that have demonstrated to us a durability that we didn't really appreciate could be possible. And Olaf will probably correct me when he comes and gives his presentation, but I now tell patients over the age of 70 that they are looking to have a durability in a tissue valve of perhaps 80 to 85% at 10 years. I'm not sure they understand that, but that's what I tell them. And of course, I think as tissue valves have demonstrated durability, as technologies have suggested that there may be other ways to correct tissue valves that fail in the future without open heart surgery, and by that I mean valve in valve, we've seen, if we look at the German data, we look at the UK data, the volumes of patients receiving tissue valves in even the very, very young age groups has increased considerably. Look at the volumes of patients under the age of 55 receiving tissue valves. But is this the right thing to do? What does the data say? Well, let's look at this particular slide. It's a complex slide. And on the left-hand side, we've got life expectancy. And on the bottom, we've got age of implantation. The right graph is risk of reoperation or major bleeding. Stay with the left-hand one. If you're 50 years of age, you're going to do better in terms of life expectancy with a mechanical valve than a tissue valve, according to this data. If you're 75, it's the other way around. We all accept that. The interesting point here are twofold. Firstly, if you look at the US guidance and the EU guidance, they're very different. The US guidance generally are suggesting the use of tissue valves in lower age groups in the aortic position. The crossover is at about 57, 58 years of age for life expectancy, and the crossover for major reoperation and major bleeding is perhaps about the same sort of area. What does this mean? Well, there's lots more data. And the problem with all of this data, and I'm sure that Edwards will share this with you so you can go and read it yourself. There's no point in me presenting it here today. But I would say this, that the results are very scattered. My take from all of this is that whether you put a tissue valve in the aortic or the mitral position is the big issue. Under the age of 55 or perhaps 50, there seems to be a why it is that these technologies haven't been taken up in the way we may have expected them to be taken up. Certainly the mitral valve done through a minimally invasive incision is a little bit more complicated. We don't need to use an intraclude, we can use a clamp, but despite that, you need to understand how to repair a valve first. And I think that even that is something that we're just beginning to really understand a lot better as a wider community. If we look at a recent study, 2014, a meta-analysis looking at all the published papers, including some randomized trial data, I think most surgeons, certainly those that perform mini sternotomy AVR and beyond, will agree that it takes longer to put in the valve. But they will also agree that the major adverse events are really no difference between the groups, particularly once we've negotiated the learning curve. And I think that is important. I think the learning curve for minimally invasive aortic valve replacement through a mini sternotomy is not that complicated. And of course, this meta-analysis suggests there may be actually some significant benefits potentially to be had when delivering aortic valve replacement through these incisions. If we look at mitral valve repair, it's true to say that repair is the gold standard, and we've seen volumes of repair increase both in Europe and in the UK, and I'm sure we've got a long way to go. This UK data actually is 2011, and I think since then that data's improved even better than that. So that's very promising. You know, going back to this idea that in this room, the innovators are actually really understanding and delivering some of those therapies that we know are good for our patients. And of course, with that, we've seen developments in ring design, flexible bands, rigid bands, semi-rigid bands, rings you can put in through minimally invasive incisions, tricuspid repair, and some of the really complex technologies that really facilitate redo mitral valve surgery. I think intraclude is a great technology for that sort of area. But of course, in order to understand what you can achieve in the redo setting, you really do have to embark upon these sorts of technologies in your routine practice. So I think what I want to do at this point is really set the scene with the word innovation. Innovation continues to direct the development of heart valve therapies in the current era and beyond. I think the indications for the use of bioprosthesis has increased for many reasons. I won't go into them now, it's on the slide. I think mitral valve repair, we understand, offers great long-term durability compared to tissue valves. And I think minimally invasive valve surgery really has emerged as a valuable alternative to sternotomy. So where next? Well, I think here is where we are looking to head over the next 5 to 10 years. And I think we'll start with Michael, who's going to talk to us about rapid deployment aortic valve bioprostheses in his minimally invasive program. Michael.